flexor capitularis to extensor digitorum communis, and flexor digitorum superficialis to extensor pollicis longus. What is important to say is that being the distal radial nerve palsy means that the lesion is distal to the branches going from the radial nerve to the extensor capitularis longus and brevis. And you can see here actually that he can extend from the radiocarpal level, he can extend the hand, and he has very interestingly only some extension left in the third digit. However, doing that, this is the intraoperative tenodesis, which is also very important, not to suture the tendons too tight, or not to suture the tendons too loose, because otherwise he will not be able to regain function. This is a patient about 1 year. After the operation, you can see that he regained full extension of the radioulnar joint, and you can see the extension of the digits, and if we wait a bit, we can see that he achieved some very good, not very good, but optimal extension from the extensor pollicis longus. The patient was, of course, very happy. This is a patient with median nerve injury at the level of the arm, which you had together with the nerve injury region of the brachial artery. You can see here that he has, in these lesions, they are very bad. Why? Because the patient cannot feel anything here, and he cannot have a pinch, he cannot have a grip. So the pollicis and the first digit are actually incapacitated, and the patient cannot actually use the hand. So what we did here is explore the nerve and perform the reconstruction. And then another important thing, what we did, we adapted the tendon transfer technique. Normally the tendon transfer is that we do a tenodesis in between the flexor tendons, the deep flexor tendons innervated by the ulna, which is okay, with the deep flexor tendons innervated by the median, which are bad, are not functioning anymore. And you reanimate the pollicis with the brachioradialis tendon. However, brachioradialis is somehow dorsal and not polar, where the flexors are. So what we did is we rerouted this tendon polarly in order to achieve a very good excursion of the reconstruction, so that the patient was able in the end to, you can see here, this is the Kapanji maneuver. He can very nicely have this pinch, and he still has a leg here in flexion of the first digit, but at the same time, you can see here the flexion pollicis longus moving, and he's very happy. He's feeling already has a protective sensation in the pollicis, and he can write. He can have a normal life. This is another patient which came in with the section into the cubital fossa. With is actually the same. This was a combined lesion of the median nerve with the posterior interosseous nerve. You can see here the same pattern of the paralysis, the same typical aspect of proximal median nerve paralysis. And this is the plan of the procedure. Actually, what we did for the first time here, and it worked very nicely. We did a passive, because we only had the ulna only functioning. We could not take the digitorum superficialis from the fourth finger to reanimate the pollicis. So what we did was a passive tenodesis by anastomosis end-to-end extensor capitularis brevis with flexor pollicis longus. And of course, doing the nerve reconstruction. This is the radialis, and this is the scar. And this is the nerve reconstruction going to the posterior interosseous nerve to the superficial sensitive branch. This is the median nerve, which was reconstructed in the same manner. This is the patient about 1 year after surgery. And actually, what he achieved is a very good extension from the radioulnar joint. And he still works on calibrating his movements. You can see that he drops the hand, but actually he has a good extension. We're going to see now he has a good extension into the fingers, and also into the pollicis. And he's actually, this is the tenor innervation, which is not very good, but it's optimal for the pinch. And the patient actually this debilitating paralysis is able to write again his name, which he was not able to do before we treated him. Regarding the protective sensation, he still has to recover here. Probably he will remain in some deficit. However, he feels enough of his working digits. You can see his hand is a working hand. Okay, so he feels enough for his digits to work with the hand and be very satisfied with the result, while the sensitive part of the radialis, which we reconstructed, gained absolutely 100% sensation. And this is the last case I'm going to present to you regarding nerve reconstruction. You can see here, this is a 9-year-old patient suffering a gum blast injury together with, this was initially handled by Dr. Zerano and Dr. Petru in a medical university center, where they fixed the bone and they repaired the artery, and then the patient remained with this horrifying paralysis because it was a combined median and ulnar complete avulsion. And you can see that the patient has absolutely no flexion in the digits, no flexion in the bulges. And there is the specific hyper extension of the metacarpal joints. He has no sensitivity whatsoever. And this is the exploration we performed. This is the nerve stumps. They were reconstructed during the same manner. This is the transfer we did. So we did extensor images proprius to tutor pollicis brevis, and then we did capillary dialysis angles to digitorum profundus from 2 to 5, brachial dialysis to flexus pollicis longus, and to avoid the hyperextension from the metacarpophalangeal joint, we performed volar capsule basis. And performing this type of transfers, this is the extensor images proprius, we were able to stabilize the right ulnar joint and to obtain this type of result after about 8 months of rehabilitation. I have to mention here the personality of Professor Galoshi, the chief of the rehabilitation department of Casa Austria, because without him, none of the results that you see here from the functional point of view would have been possible. And this is actually the degree. This is not optimal, but it's a functioning hand. He has extension, very nice. He has a stabilized joint, and actually he's again able to write his homework and do what he did before his terrifying lesion. This is another type of paralysis, which again is performed as a novelty and as the first time in our center. This is the axillary nerve paralysis and complete deltoid destruction. So this patient actually is not able to. This is the suprascapularis nerve is still there. This is the test, but the abduction of the arm is only performed by the transplasius muscle. And this is again very incapacitated because as you can see, the other nerves are functioning very nicely. 6 years ago, she just fell, and they put an arm cast, and then after that took the arm cast away. She remained with this paralysis. Nobody recognized it, and according to the Jiga classification, this is a flaccid shoulder, and it requires reconstruction. You cannot perform the nerve reconstruction anymore because you don't have the synapse anymore. So you need a functioning muscle that will replace the original muscle that was there initially. So what we did, we harvested a latissimus dorsi and we performed a bipolar transfer, meaning what? Meaning that we take the muscle together with the thoracodorsal nerve. We rotate the muscle, put it above the superior margin of the pec major. We rotate it so it will replace the function of the deltoid. And this is the operation, this is the muscle harvested. And this is the tunnelizing process. And this is the muscle placed, ready to be sutured. And after 4 weeks of immobilization and after 4 months of active range of motion, you can see here first the aesthetical part, which is also important, but moreover, you can see the functional part. Patient is required to contract the latissimus. You can see here very nicely the round profile and how it contracts. And while this was preoperatively, okay, this is the result we achieved postoperatively. And after some time of rehabilitation, this is 1.5 months. Actually, this is the patient performing first. This is an N2, so she can contract against some force, and this is actually an N3 plus, with the patient being able to abduct the hand actually normally. She actually hired herself as a cleaning woman 1 year after the operation, telling us that our reconstruction was successful in an arm that previously was not functioning anymore. Looking at the results, these are two patients that we lost. Of course, all the single nerve paralysis achieved the best functional result, which was about to be expected. The common peroneal nerve reconstruction with the functional reconstruction achieved according to the low extremity functional score. Very good increase from 11% to 62%, and from 9% to 56% in these two patients who performed. And of course, multiple lesions lead to a not such a nice functional result. However, in the young boy we operated on, the result was M4, and this is probably explained to the brain plasticity of children, which is much better than the adults. And I will come now to the last part of my talk, and we will change with the subject to another very interesting chapter, which are the perfect flaps. What is a perfect flap? We plastic surgeons like to cover defects all over the body, which you all know. So when we cover those defects, we use flaps, and those flaps are chunks of tissues that we harvest with their vessels, and then we anastomose the vessels wherever we want to cover the defect with. However, in order to get this chunk of tissue with the vessels, until now, you have to take the muscle where the vessel will go on through. So the new concept is that you actually take the perforating branches from the muscle, you dissect down into the muscle, go to the main trunks, and then take the tissue you want, and you transplant it into the region you want to reconstruct. Why you do that? Because by doing that, you are not deranging in any circumstance the functional anatomy of the body region where you take a flap from. And this is the evidence we have. I'm not going to insist on that because this is specific for plastic surgeons. Anyhow, I will tell you that the studies, the initial anatomical studies of Taylor and Palmer regarding the angiosomes were the emerging point for this type of concept, which was further on followed by Koshina, Blondil, and so on and so forth. What is important, it is important for the cases I'm going to show you, is that the one that promoted what is called the local perforated flap, which I will explain what it is Theo Tiu, and he has been here to Timișoara, and it was through his presentations and his power of convincement that we started to do, and actually we performed the first ever local perforated flap in this medical university. And this is a perforated flap. So this is another lateral thigh flap. I just want to explain the anatomy. This is the descending branch of the lateral circumflex femoral artery. This is the vastus lateralis muscle, and this is the perforator going normally through the vastus lateralis. So if I want to take normally this fat and skin, I'd have to take the muscle together with the vessel. But between the perforated flap, I'm only taking the perforator, I'm just dissecting the muscle, suturing that, no disturbance of the anatomy, and I'm taking the perforator together with the pedicle and the flap I need. And I will show you how we use that. And of course, in the end, we leave a very nice card, and the patients are happy. Perforated flaps are enormously versatile. Okay, and I will just try to convince you by giving some examples. This is the local perforated flap, meaning that you take a chunk of fat tissue and skin, and this is a perforated vessels coming above the muscle, and then cut these tissues on the vessel, and you rotate this flap, and you use to cover, this was a lateral malleolus in a diabetic patient, which was with osteomyelitis. You can see how nicely it bleeds. So you can use them as local, meaning that you don't need microsurgery to revascularize those flaps. Or you can use those flaps, as I've shown. This is an lateral thigh flap, dissected, ready to be transferred. This is the location where the perforator goes into the skin and the fascia. And this is the space that has been dissected. You can see here the fascia, you can see here the flap, and you can see here actually the pedicle of the flap. And I don't know if this is to be observed. Now this is the muscle dissected, and this is the perforator very nicely going in the fascia, nourishing this entire huge piece of tissue. You can see here the perforator pulsing. They can be adipofascial flaps. This is an adipofascial flap based on the perforator on the ulnar artery, what I have used in emergency to cover and expose first metatarsophalangeal joint. They can be fasciocutaneous, they can be compound. This is an anterolateral thigh flap taken with the fascia lata to reconstruct other structures that need fascia lata, for example. I will show you. And you can take masdermofascial cutaneous iron. You can take them as ellipse. You can take them as hockey sticks. So it gives you the possibility to be inventive, the possibility to employ freestyle, the possibility to choose the perfect option for your patient. And this is the case series we did with 38 patients in between 2007 and 2013. And most of them, I told you about the vascular surgery department. Of course, patients that have creatinine disease have lots of other comorbidities attached to them. So we found out that this type of local peripheral flows are very good to reconstruct those patients which are coming with lesions. And nevertheless, this is a very in 2011 published paper which is telling us that comorbidities, except for smoking and diabetes, do not influence a lot the rate of survival of labs. So, case examples, just to exemplify again, this is a case of Achilles tendon which has been multiply operating on, and unfortunately it went wrong. And this is the defect in the Achilles tendon, what we have found out. This is a fantastic operation in the front of the mark, and this is actually the first compound perforator flap we used in the clinic. And this is the flap.